Can you see my
Sir,
face?
it is visible now.
Yes, visible.
Yeah, so this is a hospital where I work. It's in the heart of Warsaw, as I said, in Poland. And I'm currently the chair of diabetology in the internal medicine department, which is a 40-bed hospital department. We are fighting COVID fiercely. At present, I'm actually closed as a couple of my nurses were found to be positive with COVID-19. So we struggle like the whole country and the whole world, I believe. So my task today here is to present you top 10 papers presented in ADA, and I thank Banshi Sabu for offering me this talk and this title, which is a challenge you can imagine. It's ADA just ended on Tuesday, over 800 presentations. Choosing the top 10 is really a hard task. So what you will see is just my personal choice. I'm describe myself as a clinical researcher, but I'm more probably a clinician than a writer of scientific papers. That's what I spend most of my time with patients. So the papers will be mostly clinical, and as I said, it's a totally subjective and personal view, and I'm happy to discuss it or argue later on. So let's start with number 10. I will make a countdown to 1. It is supposed to be a chart. So number 10, I would make maybe not a paper, but a session, a symposium on metabolic rhythms. Dr. Josiane Broussard, a very well published author in the subject, argued that any changes in sleep pattern, first of all, shortening the sleep, and we see it across the world in the last 2-3 decades that we sleep less and less. This is a strong contributor to metabolic disorders. She gave an example showing this study, for example, that just having short sleep for one night starts or causes insulin resistance, which is equal to high-fat diet used for 6 months and normal sleep. So this is probably an underappreciated element in a lifestyle, which we do not address when we talk to the patients, which might be responsible for at least part of metabolic derangements. Her partner or opponent in this symposium, it was a sort of a debate, was Dr. Andrew McHill, who argued that it's not the sleep itself, it's the eating pattern, because what he concluded was, and I'm just showing conclusions from his presentations, have to be able to squeeze 10 papers in 25 minutes, that it's not really a sleep loss, but if you sleep less, you have more time to eat. And he showed data then people who sleep 5 hours instead of 8 or 9 simply have more post-dinner snacks. So I'm not sure if we should conclude that we may treat diabetes with sleeping pills, just a patient sleeps more than they will be eating less, but that's the kind of a conclusion he reached. So this was a stimulating and provocative debate, but first of all, it put direct our attention to sleeping problems and the relationships with glucose control. So number 9 is the symposium and session on oral treatment of diabetes in pregnancy. There were 2 outstanding female speakers, Dr. Denise Feig. She was talking about type 2 issues, pregnant women with type 2 diabetes. We see, I guess, worldwide increasing number of women who are pregnant and who are already diagnosed with type 2. They are on oral agents. And then there's a question whether we should continue metformin on other oral medications or switch them immediately to insulin. So she was a stronger defender of metformin use, if not throughout the whole pregnancy, at least through the first trimester. And she also, I'm showing you her picture because you may also appreciate during the ADA where people were recording their presentation. It all happened about a week before ADA. Each presenter recorded his or her presentation wherever they thought it would be suitable. It was sometimes a workplace, but also at home in their living rooms. Here you can see a kitchen, so we can also see some private parts of the private lives of the eminent speakers. Her opponent here was Dr. Linda Barbour. from US, a very respected scientist and practitioner in that area. She was more also discussing other oral medications, not just in type 2 diabetes, but in gestational diabetes. And that were her conclusions, which I would like to share with you. She argued that metformin is okay for the first trimester of pregnancy in GDM or in type 2 diabetes. It's more questionable in the second and third trimester, but overall, it is a safe medication. The only question mark over metformin, which is now getting bigger and bigger, is the effect of metformin use in pregnancy on children, because the hypothesis, which was most convincing during this symposium, which was presented, was that pregnant women who take metformin, metformin decreases the access to fuel, to energy, and then the children who are born by mothers who are treated with metformin during pregnancy, they have rebound, those children, the rebound in the growth rate, and they simply become a little bit more heavier and a little bit more obese when they have 5, 10, 15 years of age. So that's a question mark about metformin. This was a very interesting discussion between those two ladies. Dr. Barbour also defended glyburide, which might be used. It might be combined with insulins, as you can see here. There was also the question of metformin, which is not absorbed, which stays in the intestines, and the name of it's metformin DR. We wait for the studies. There's also an idea that that use of metformin might improve glucose control. So there are studies coming up. The most important one is a MIGHTY study, where the children will be followed up for some time, a few hundreds of women taking metformin or metformin with insulin. Also, an issue which was raised, that metformin is not a very potent drug in pregnancy. In many studies, at least half of women who were taking metformin during the pregnancy required insulin at the end of pregnancy. Again, a very interesting issue and a very practical one. Number 8, Dr. Ahmed El-Hussein from Boston presented data on the racial disparities in the access to the best care, or the differences between races in US, exactly in a look-ahead study, how treatment was intensified depending on the race of the patient. So currently, we might say it is an sensitive and important and a very topical issue. And what he showed, that comparing to the whites, this is the reference level here, the blacks, but especially Native Americans, are less likely to be put on a more intensive treatment when their diabetes deteriorates. So somehow doctors, this was unsaid suggestion, look a little bit less carefully on people of color in US. Interestingly, this differences disappeared when it was looked at the education level, when it was looked at the places where people are getting their care, and also in the insurance type. The other important difference was level of income, which was to be expected. People who have lower income are less intensively treated. So that's a take-home message that still, although we all declare that we are colorblind in medicine, apparently in US, the doctors are not. It's even more visible if you look at the curves. This is the time to event, and event is adding another medication. And this green curve are Native Americans. So Northern Americans, Indians, as you might say, traditionally, they are especially worse off. This dark curve at the top are white patients. So something for Americans to look after, but also to remember, I guess, across the world. Number 7 in my list is the data presented by Dr. John Dennis from University of Exeter, who elaborated on precision medicine in type 2 diabetes. There was again a whole session, very interesting one, which followed up the concept of clusters, 5 clusters of type 2 diabetes, presented 2-3 years ago by the Life group by Emma Alquist. She also took part in this symposium. But what John Dennis showed was he argued that when you use those clusters concept, we know that there is an insulin deficient cluster, people who develop retinopathy more sooner, or insulin resistant cluster predisposing to chronic kidney disease. And there are two clusters with something which is called like mild. I don't like the word mild about diabetes, but originally they called it mild obesity related and age related diabetes. And if you look at the efficacy of different drug groups, because the precision medicine is all about helping us making better choices in terms of the treatment, and we have more and more options, more and more drugs, we have more classes, but also within class of each medication, we have more agents and which agent to choose. So these clusters are thought to help us to choose the medication, all for the good of the patients, of course. But if you look here for the 3-year follow-up period, really, it's hard to say which medication is really significantly better. It's each of them at some stage of the disease is better than the other. If you take into account this cluster hypothesis. So what he did is what they developed in the University of Exeter. They developed a sort of a digital tool which is not taking any complicated data, but as you can see, HbA1c, age, gender, BMI, and so on, a very simple clinical variables. And when you put them into the when you enter them into the interface, then you get some sort of analysis which tells you which drugs gives you the highest chance of achieving target HbA1c at 12 months. And for this gentleman, it's the sulfonylurea. For this lady who has the same HbA1c, because that's the trick here, it's the same HbA1c, 75 millimoles per mole. So if it is the same, and of course they have no cardiovascular complications, because if they have, the choice is easier. If they do not have, we have more drugs to choose from. So in her case, she's older than this gentleman and she's more obese. Here, TZDs and pioglitazone seems to be the drug which will be most effective. So that's the moment where we are. We might be getting, this is now undergoing a study, and we might be getting more sort of a decision aids to choose oral agents for our patients. Number 6 is the type 1 study, which I want to show you briefly to you. It's the study presented by Emily Palisaitis from McGill University in Canada. They developed an additional part of the artificial pancreas algorithm, the part which they called meal detection algorithm. The study they presented, very interesting one, 11 patients only. They underwent 3 types in various order, 3 types of intervention. They were put on conventional pump therapy. There were 15-year-old type 1 patients, mostly girls. Then on artificial pancreas, so with algorithm which worked as an artificial pancreas, and then artificial pancreas with a special addition of algorithm which detected the meal just by analyzing the changes of the glucose level and the changes of insulin to carbohydrate ratio. So the patient does not have to make a bolus themselves. The pump, which works as an artificial pancreas, is likely to detect the moment the patient has started the meal. So if you look at the results, how postprandial glucose was controlled with this additional part of the algorithm, the yellow curve shows the artificial pancreas with meal detection algorithm, and this was the most effective. Then increase in insulin delivery was a little bit earlier than the regular artificial pancreas without bolusing, because that would make a huge difference. It was the idea that the patient simply does not have to make any intervention. The pump itself will deliver more insulin. And this meal detection algorithm increased combined basal and also mealtime. It simply added more time, more insulin as a bolus, and also increased basal infusion rate. So that sort of approach allowed the decrease the curve, the area under the curve of glucose in this figure, and it allowed, by decreasing only 65% of the regular bolus insulin, to control quite effectively postprandial glucose. The 65%, not 100%, because of the delay in this detection. The bolus is detected, the meal is detected about 30 to 40 minutes after the meal initiation. So that's a very interesting direction in which new technologies develop in type 1 diabetes. Number five, I guess this is a controversial study, but also very much thought-provoking. Silvio Inzuppi showed the data on the dapagliflozin effect on the diabetes prevalence. So this is the first study which shows that we might start looking at SGLT2 inhibitors as the agents which are able to prevent, which probably we could put prevented today at inverted commas, prevent diabetes. Of course, DAPA-HF was not the study to assess dapagliflozin effects on diabetes prevention, but what they noticed is that as they had majority of patients in the study without diabetes, Professor Per-Henry Group just mentioned other studies on kidneys where there are also patients without diabetes, but taking SGLT2 inhibitors are included. This was the one study with heart failure. 55% had no diabetes, and during the study, a little over 150 patients developed diabetes. And what they noticed is that those who were taking dapagliflozin, by 32%, the risk to develop diabetes was lower. But there are a number of issues here. Diabetes was diagnosed only by HbA1c. You may argue that it's somehow a risky analysis, but the data are interesting here. And as Silvio also showed, those who did develop diabetes, new onset type 2 diabetes, they had higher risk of all-cause mortality, of cardiovascular death, and of heart failure hospitalization, more than doubled. So maybe the benefits of SGLT2 inhibitors, when they are used in non-diabetes patients, comes not just from their effects on cardiovascular system and kidneys, but also on delaying or maintaining glucose control, because most of those who developed type 2 diabetes were already in pre-diabetes stage. So by just prolonging pre-diabetes and delaying diabetes development, it also provides cardiovascular and simply decreasing mortality benefits. An interesting approach. I guess this study will be largely commended, mostly due to its controversy in methodology. So we are approaching podium number 4. I will also refer, you will see that the top of my list are studies about the drugs, because this is what we are most interested in. There are so many agents now, so many data. We have to make informed choices. So these are the studies which attracted a lot of attention. So number 4 is the study with empagliflozin. It's the part of the analysis from the EMPERG outcome. This was delivered by Dr. Mufathaya Vaduganathan. And as you can see here, he showed that using empagliflozin in EMPERG outcome in those patients who were not on insulin at baseline decreased the risk of initiating insulin by 60%, which is a really, really important effect. It may be used when we have to discuss the reimbursement issues with the governments, because it really also saves costs of diabetes treatment, not just the cost of insulin, but all the complications related to insulin use. And this reduction in the need for insulin initiation was not trivial. If you look here, it is 20% of people on placebo required insulin, and less than half of this amount required insulin among those who were taking empagliflozin. The other analysis was the effect of not needing to increase insulin by more than 20% among those who were already on insulin at baseline, and the effect was very similar. So SGLT2 inhibitors might also be now viewed as the drugs which delay insulin therapy. We had similar data on sitagliptin from TICOS study. Here we have the new data from EMPERG outcome. This is this 20% increase in insulin dose effect. Also, as you can see here, is the reduction of the risk greater than 50%. And now let's go to the podium. Number 3 is the VERITIS trial. I guess it is an important study. This is in addition to what Professor Per-Henry Group just were saying about SGLT2 inhibitors. This is yet another study on SGLT2 inhibitors assessing cardiovascular safety, cardiovascular outcomes. And the study was not as surprising as it would have been if MSD and Pfizer had not decided to publish a press release about 6 weeks before the ADA. But what was surprising still was that the study showed no effect of erythropoiesis and no statistically significant effect on MACE. And it was surprising for one reason, for many reasons, but for one reason for sure, that the study population was very similar to the one which was taking part in EMPERAG outcome. Everyone had cardiovascular disease. Half of these people had myocardial infarction. Almost a quarter who had already had a stroke. Still, no effect on MACE, no effect on cardiovascular death, virtually none. However, expected effect on risk for heart failure hospitalization. So if we look at the issue now, or the class effect of SGLT2 inhibitors, because this study, in my view, and many of my colleagues, kills the idea of class effect of SGLT2 inhibitors, at least universal class effect across the whole area where these drugs exert their effects. We may still claim that there is a class effect in heart failure. We see very similar reduction in all 4 major SGLT2 inhibitor studies in CVOTs, but definitely not a class effect on the effect on cardiovascular death on MACE. Why? What are the reasons? The list is very long of hypotheses. This study will also be hugely commented. Number two, we are all in diabetes, and the king of the drug of diabetes in my country, it would be the queen, because insulin is feminine, is the study on insulin. And I think this is a very inspiring data coming from Julio Rosenstock, the data on comparing of new once weekly basal insulin icodec as compared with glargine in a very well designed and conducted randomized double-blind study. I guess many of the ADA participants heard for the first time that insulin might be given once weekly as a basal one with equal efficacy as the glargine. This is what the icodec looks like. There are 3 amino acid substitutions, and this is the product of Novo Nordisk. And they use the same technology as is used in semaglutide, because this is the spacer, and this is the same spacer which is used in semaglutide, which simply let the insulin to bind with human albumin, plasma albumins, and from these albumins, insulin is slowly released after a few weeks. So the few weeks are needed to achieve a steady state. And what Julio showed is, as you can see, almost equal efficacy in terms of lowering HbA1c from about 8% to below 7%. This is the improvement in daily profile as assessed with SMBG over imposing curves. This is the insulin dosage, also a very interesting thing. Look at the weekly dosage of insulin, and this is the dose which is given once a week, over 200 units of insulin. So that's kind of interesting figure to get used to. Patients on icodec required less insulin than on glargine. The weight gain was very similar, decreased from 8 to below 7. The patients put about 1.5 kilos on their weight. With icodec, the hypoglycemia alerts were more frequent, but severe hypoglycemia rate was similar, and also the duration of hypos was not longer with long-acting insulin. And I guess that's a very important and interesting study, because we just within 20 years, glargine arrived exactly 20 years ago. We're moving from long-acting analogs given once daily to be very close to be using long-acting analogs once a week, preferably together with once weekly GLP-1 agonists. So I guess this is an important study, not just for the concepts, but also for clinical practice. And number one, you might be surprising, because number one on my podium is actually empty. I would put here any important paper on diabetes and COVID-19 pandemic, and there was none. And of course, the ADA program was prepared a few months before pandemic started. But during this Congress, which has also not been prepared yesterday, there is a whole session on COVID-19. There is an explosion of papers on COVID-19. And diabetes patients are an important group, which is supposed to be at greater risk of COVID-19 course and death. And still, there was not a single paper or lecture on COVID-19 and diabetes. And I think this is a major blunder. They really should be able to put an extra lecture or extra state-of-the-art presentation on COVID situation in US, where they have so many patients. So my number one is actually empty. And just to make matters worse, this is my last slide. Just want to show you what they did find time to present. This is the slide I stole from the presentation of ADA president, who when he mentioned the possible environmental factors associated with type 1 diabetes development, he even managed to mention climate, which I guess is a long shot, and you can hardly argue that climate changes might increase the rate of type 1 diabetes. So this was covered, climate change, but COVID-19 was not, which I think is really regrettable. Thank you very much for your attention. Sorry for this goulash or potpourri of various studies, but that's what Bashi wanted me to do. I tried to do my best. Thank you.
No, thank you, Dr.